Hi, thank you very much for having me. If I'm speaking into this, hopefully you can hear me pretty good. If you can't, I will talk louder. Just let me know. So last time I gave a talk on unruptured brain aneurysms, and so now I will give a talk on ruptured brain aneurysms. I don't have any disclosures. Nobody gives me money for anything. So here's a quick outline. We'll talk about the epidemiology of ruptured aneurysms. We'll talk about the prognosis and the grading systems. We'll discuss clipping versus coiling, and we'll talk about the management of delayed cerebral ischemia, which is a complication after ruptured aneurysm. And then the last part is going to be new advances, kind of cutting edge topics and things like that for management of ruptured aneurysms. So we say that the prevalence of brain aneurysms in about 3% of patients. Usually it's female predominant, and then the risk of rupture is 10 in 100,000. The morbidity is quite high for a ruptured aneurysm, and the mortality is also quite high for ruptured aneurysm. So again, we like to identify them and treat them before they rupture, but if they do rupture, there's a pretty bad prognosis. So risk factors for developing aneurysms, we talk about untreated high blood pressure, chronic hypertension. Cigarette smoking is definitely a risk factor. Older age, and then in different parts of the world, we have different drugs that people use. In Portland, we have a high concentration of people who use amphetamines, and these are sympathomimetic drugs that increase your blood pressure, increase your sympathetic tone, and push your blood pressure very, very high, very rapidly and acutely. The other thing is family history. So we do think that family history can contribute to aneurysms, but as of yet, we don't have any genetic screening or anything like that. But current guidelines are that if you have 2 first-degree relatives with aneurysms, then the whole adult family should get screened, either with a CTA or an MRA, because the likelihood of having an aneurysm is quite high. So these are symptoms for unruptured aneurysms, potentially headache, eye pain, paresthesias, weakness, maybe weakness of the face, pupil dilatation for maybe a third nerve palsy, vision changes or double vision. But for ruptured aneurysms, these are the classic symptoms: a sudden onset, worst headache of life, nausea, vomiting. A neurologic deficit can include weakness or numbness, paralysis, and then some patients can progress to coma depending on how severe the hemorrhage is. So we have 2 grading systems for ruptured aneurysms. We have the World Federation of Neurological Surgery grade, and we have the Hunt-Hess grade. This is an older grade, and as you can see, the grading system is more generalized, meaning stuporous, moribund. These are kind of subjective terms to grade how severe the clinical presentation is. The WFNS grade is more objective, using the GCS as its primary grading system, and with or without motor deficit is a caveat to differentiate some of the different grades. So we're mostly using the WFNS grade here just because it's easier to identify grade 5 versus grade 4 based on GCS. In the Hunt-Hess grade, someone is stuporous versus moribund. Those are 2 words that are fairly similar. So, grading these is easier for differentiating low grade, 1 to 3 versus high grade, 4 and 5. So, in addition to the clinical grade, there is the radiographic grade based on the admission head CT. This is called the modified Fisher score. This is a modification of the original Fisher score, and the radiographic grade predicts your development of DCI, as you see over on the right-hand corner. So low grade to high grade increases your risk for development of DCI and vasospasm and things like that. So the key characteristic is whether or not you have thick subarachnoid hemorrhage, and that's probably the biggest predictor of development of delayed cerebral ischemia. So this is a CT panel showing the progression from modified Fisher 1 with thin subarachnoid hemorrhage to thin subarachnoid hemorrhage with intraventricular hemorrhage, and then 3 is thick subarachnoid hemorrhage without intraventricular hemorrhage, and then 4 is thick subarachnoid hemorrhage with intraventricular hemorrhage. So the primary driving characteristic is the thick or thin cisternal subarachnoid hemorrhage. So we'll talk about a case. These are cases that presented to our hospital the week prior to leaving, so they're pretty recent. The first case is a 45-year-old female. She has no medical history. She witnessed a syncopal event in a fall. Her blood pressure was known to be 220 and over 120 by paramedics. She was found with drug use near her, so she was positive for methamphetamines. And this is likely why her blood pressure was 220, because she's 45 years old and doesn't have a history of hypertension. This is her clinical exam. She's eyes closed, she's intubated, and she withdraws all extremities. So her GCS is 6. So that puts her at WFNS grade 5, Hunt grade 5, and her CT scan, as we'll show you, is a modified Fisher grade 4. So this is her CT scan. You see thick subretinal hemorrhage. You see a little little hematoma here, and you see some intraventricular hemorrhage. You see a little bit of blood in the occipital horn of the lateral ventricle. So here's her CTA. There looks like to be an aneurysm in the right posterior communicating artery here on the axial and the sagittals. This is a CT scan showing the ventriculostomy that was placed. It's not ideal, but it's working, so we left it. And here's her angiogram. So the angiogram shows a fairly large right posterior communicating artery aneurysm. This is a fetal posterior communicating artery here, and so this is where her rupture comes from. So here's a 3D angiogram. We have a PCOM aneurysm. We see the fetal PCOM coming off the neck of the aneurysm, and here you see a little bump here. That's the anterior choroidal artery here. So we'll keep her in mind as we go through the next few slides. So the medical complications of subretinal hemorrhage include fever, anemia, hyperglycemia, hyponatremia, usually from CSW, which is cerebral salt wasting. Patients can get pneumonia either from ventilator-associated pneumonia or from intubation because they're usually intubated in an emergent fashion. Hypertension can happen because there's a loss of autoregulation of blood pressure in the brain. And then neurogenic cardiopulmonary dysfunction. So we'll often see pulmonary edema. We'll often see a Takotsubo cardiomyopathy, which is a akinesis or hypokinesis of the apical portion of the heart. So this is the stress cardiomyopathy that we often see after subretinal hemorrhage. So all of these medical problems can occur at different stages of the post-hemorrhagic phase. We have to address them as they arise and as they come up, okay? So the initial management of the aneurysm of the patient is to follow your ABCs: airway, breathing, circulation. So she is not protecting her airway because her exam is poor, so she gets intubated. We control the blood pressure very aggressively because we want to reduce the risk of re-rupture of the aneurysm. So the best data that we have suggests that a systolic below 140 millimeters of mercury is protective and reduces the risk of re-rupture. Is there a question? If you have questions, please feel free to answer. Raise your hand or let me know. Happy to answer. So this is very important. This strict blood pressure control. So we'll often place people on nicardipine drips. We often give people hydralazine, labetalol. These are all drugs to reduce the blood pressure in the acute phase so that we reduce the risk of re-rupture. Hydrocephalus is something that needs to be treated. So patients will develop hydrocephalus, and that's with ventriculostomy. We usually put one at Coker's Point. It's the easiest place to put a ventriculostomy, and it's done at the bedside by the resident, usually in the middle of the night. If they're on anticoagulation, we reverse it. We give them prothrombin complex concentrates, Kcentra, Novo7. I'm not sure what you guys have here, but agents to reverse anticoagulation. And then we secure the aneurysm usually within 24 hours. This is a little bit controversial in some places. Some places say if you have the team available, you should secure it when the patient arrives. But I would say the vast majority of evidence doesn't support that immediate treatment. It supports treatment within the first 24 hours because that's the highest risk of re-rupture of the aneurysm. Okay, and then we can talk about how to treat that. So now, clipping versus coiling. Okay, so in this last patient, she's 45 years old. She's a young patient. There's a fetal PCOM. She's a high-grade aneurysm rupture, so high clinical grade. These things may favor clipping of the aneurysm. Okay. Coiling, she's got a favorable dome to neck ratio. It's a pretty spherical aneurysm that may be amenable to coil embolization. The other thing is she's on drugs. And so in my experience, I worry about manipulation of the blood vessels in the context of being on these sympathomimetic drugs. So if I'm doing a vessel dissection, I worry about causing spasm by touching all the vessels on the, from the outside to the inside, and then we can induce risk for stroke. So in this patient, I elected to coil the aneurysm. Okay, and so this is our angio after we're done. We have a nice coil mass. We have a PCOM that's still open, and so this looks like a very, very nice result. Okay, after treatment of the aneurysm, we can start to change our management because we're now in the phase after securing the aneurysm. Okay, so instead of having systolic less than 140, we can have systolic less than 180. And this can potentially help with vasospasm and augmenting blood pressures to increase perfusion of the brain when you have vasospasm. So vasospasm usually happens in post-bleed day 6, 7, 8, 9, that kind of time frame. So we allow them to auto-press if they need to increase perfusion to the brain. Okay, we want to maintain at least 35 to 145 milliequivalents per liter in the blood sample. We can treat them with normal saline, we can treat them with hypertonic saline, and we have different concentrations of which 3% NaCl or sodium bicarbonate so that we can reduce the risk of metabolic acidosis. 7% we can use in case we don't want to volume overload the patient. And then this is what we call a bullet, a 23.4% dose of saline. This comes in a 20 cc syringe, and it's given over 20 minutes. But this is a way to significantly increase your serum sodium without introducing significant volume for the patient. Okay. Euvolemia, this is very important because we worry about hypovolemia in the context of vasospasm and hypoperfusion of the brain. And so so a lot of our therapies are directed toward maintaining euvolemia with their fluid status. Glycemic control is very important. And then oral nimodipine. This is one of the drugs that has been proven to reduce the risk of stroke after DCI. It's not very strong evidence, but it is the best evidence that we have. And so we place people on nimodipine, 60 milligrams every 4 hours for 21 days or discharge from the hospital, whichever is sooner. And so this is a medication that we give to everybody who has something hemorrhage. And then part of our protocol is the daily TCD. So every morning we have a tech that comes and does a TCD on the patient to assess for flow through the MCA territory, flow through the basilar, and to assess changes from day to day on how much the vessel is getting narrowed. Okay. So for that patient, she was extubated on hospital day number 3. She was reintubated on hospital day number 5 for a worsening exam. We sent her for a repeat angio on hospital day number 6 because even with blood pressure augmentation and hyperperfusion, she still didn't improve. And so I will show you here. So this is the initial angiogram prior to embolization, showing the caliber of the vessel. And here is the angiogram showing the vasospasm. And you can see that there's definitely decreasing caliber of the aSAH territory, the MCA territory, and even, almost the supraclinoid ICA and the cavernous ICA. So we give intraarterial verapamil to treat the spasm. That's part of our protocol. Some people do balloon angioplasty. There are stent devices that you can deploy within the vessels to improve the luminal diameter. But all of these things are kind of experimental therapy. Intraarterial verapamil or intraarterial calcium channel blockers are relatively safe. They work on the entire circulation, we think, and they can reduce the reduction in caliber of the blood vessels after administration. So she got 10 milligrams of intraarterial verapamil for this circulation into the ICA injection. Okay, she's still in the hospital. She has an EVD. She needs to get weaned from her shunt, and so we'll see how she does. The next case. This is a 75-year-old female she was shopping in the market, had a single pull event, fell down, and then hit her head. Her medical history: she's hypertensive at baseline. She has hyperlipidemia at baseline. This is her exam at the outside hospital. She's E1, she's intubated, and she's extending her right upper exam. So she's a very high grade. She's WFNS grade 5, Hunt test grade 5, and she's modified Fisher grade 4. This is her initial CT scan. Again, we see thick, diffuse subarachnoid hemorrhage. We see subarachnoid hemorrhage in the sylvian fissures bilaterally. We see a small subdural hematoma for where she fell. We see a subgaleal hematoma from where she hit her head. And then again, we see a little hematoma here in the right temporal lobe. So again, we're thinking that she has an aneurysm because of the characteristic of the blood, and that's what we're going to see. So this is our CTA. We see a small aneurysm in the region of the posterior communicating artery, just like the last patient. Here's the EVD, the ventriculostomy, and again here, right here, is the aneurysm here, and you see the posterior communicating artery here. So here's the angiogram. Here's an irregular right posterior communicating artery aneurysm, and here it is again. This right panel shows the left vertebral artery injection, but one thing to realize is that she does not have a fetal PCOM. There is some flow through the PCA territory from the basilar. So this is a large PCOM, but it's not a fetal PCOM. Okay? So, and here's our 3D angiogram. So you see an irregular aneurysm here in the posterior communicating. Here's the PCOM itself coming here, and then this is the rest of the PCA coming out that way. Okay? So again, we discussed clip versus coil. She's an older patient. She's developed cardiac dysfunction, so she's developed some degree of Takotsubo's cardiomyopathy. So the cardiac anesthesiologists say, hey, her blood pressure isn't great. She's not a great candidate for surgery. Do you still want to do surgery? She is definitely a high-grade rupture, and then the aneurysm is pretty irregular. So I decided to take this patient for clipping just because of the irregularity of the aneurysm, and I was worried that there was a thrombosed portion that was not visualized on the angiogram or the CTA. And here's the craniotomy, here's the clip, and here's the 3D showing the aneurysm is gone. So I also ended up doing a craniectomy. So for high-grade patients, I favor doing a primary craniectomy, leaving the bone off, because I think that I don't want to run the risk of getting a call in the middle of the night from the intensivist saying, the ICP is high, we're not able to control pressures, can you come and do a decompression? So I just say, just do it at the very beginning, and then I get to sleep better at night. So here's her post-op CT scan. We see the craniectomy that's off. She's intubated, she localizes, she withdraws. Her exam is better than it was when she showed up, and so we'll see how she does. She's developing a little bit of external hydrocephalus here. You see a little bit of external hydrocephalus on the left side. So I suspect she's going to need a shunt at some point. Okay. The last case that I will show is a 71-year-old with sudden onset worst headache of life. Her medical history, diabetes, hypothyroidism, a long smoking history. She's intact, GCS 15. Okay, so she's very low-grade rupture. This is her admission CT scan. She has thick, diffuse subarachnoid hemorrhage. She has hemorrhage in the inner hemispheric fissure. She has hemorrhage in the sylvian fissures bilaterally. Okay, here's her CTA. CTA shows a small 2 to 3 millimeter ACOM aneurysm. Okay, and you can see it on the coronal projection here. So here's her angiogram. You see that aneurysm here again. This is a 3D, so the numbers here, she's maybe 4.5 millimeters in one dimension, but it's irregular. And then the neck is probably 2.5 to 3 millimeters in diameter. So again, do we clip or coil? She's an older patient. It's a small aneurysm. It's irregular. She's intact. And for ACOM, I think the ACOM projection is really what helps decide if I want to clip or coil this aneurysm. So here's a cartoon showing the orientation of the ICA, the A1, and the cranial nerves. So aneurysms that are anteriorly projecting are relatively easy to clip because they're in our view and we see them quite easily when you do the craniotomy. Aneurysms that are posterior projecting can be hidden beneath the A2 or beneath the A1. So with her case, she had a kind of anterior superior projecting aneurysm. I could get a pretty good view of it on the angio, and she's intact. So I decided to offer coiling for the patient. And here's our final result. We coil the aneurysm, and she's doing fine. So I think with the improvement in devices, improvement in technology, we're able to more safely coil aneurysms, where previously we probably would have ended up clipping them. So one of the reasons why I wanted to coil is because she was doing so well. And so to exposure to a craniotomy when she's doing fine made me feel not the best. And so post-op day one, she was texting on her phone, she was calling her friends, she's saying, I'm in the hospital. So I think that's a win. Okay. So this is our kind of protocol for managing ruptured aneurysms. After rupture, less than 140. After securing, up to 180. And then if they have clinical signs of spasm, we may even push the pressures to 200, 210 to increase perfusion to the brain. CSF diversion, so almost everybody gets an EVD. We set it at 15 or 20 centimeters above the trachea, and we let it drain. We open it. Some people don't want to open it because they don't want to risk the re-rupture of the aneurysm. In our experience, it hasn't really been the case where opening the EVD increases risk of rupture. So we do it. I know many places who will not open the EVD because they don't want to risk the rupture of the aneurysm, but I don't think our experience shows any increased risk for rupture. We do daily TCDs. We do nimodipine. We follow sodiums. We follow volumes. And there are many ways to follow volume for a patient like this. Von Ganz catheters we can place. Pico is another a device that we can place. I'm not sure if you're familiar with this device. And then we use a iodinated albumin study to assess for blood volume. This is a pretty new method, and I'll show you some slides on it in a second. And then we usually do an angiogram around postally day 7 or 8, or when clinically indicated. So the first patient had an angiogram on day 6 because she was getting worse. So if your exam is worse, we'll do an angiogram earlier. If your exam is okay, we may wait till 7 or 8 days later to do the angiogram. There's no progressive enlargement of the aneurysm to make sure if you clip it, it's gone. And so that's a good assessment. And then, if they have we plan for the shunt after the EVD. And I've gone away from weaning the shunt. We used to say, okay, the EVD is at 15. We'll keep it at 15 for a day. We'll go to 20 for a day. We'll close it off for a day, and then we'll see how it goes. I just go close it and get a CT, and if it's fine, take it out or put a shunt in. I've found that it has reduced my ICU stays by at least 2 or 3 days for these patients because I'm not weaning them. So that's just a practice change I've made in the last few years. Okay, so management with a PICO. So this is called a pulse contour analysis with transpulmonary thermodilution. It can assess pulmonary edema, it can assess cardiac preload, it can assess afterload, and cardiac. All these things it can assess by giving you numbers out of the machine. It works by this technique called transpulmonary thermodilution. So you have to have a central line, either an IJ or a subclavian, and you have to have an arterial line, either a femoral line or a radial line or a brachial line, something in the venous and something in the arterial. We tend to put a IJ central line and a femoral arterial line. You inject cold saline through the central venous line. The cold saline mixes with blood and passes through the heart, the pulmonary vessels, and back through the heart. And then the arterial line picks up a decrease in the temperature of the blood as this saline bolus is going through. And the second part of it is called the pulse contour analysis. So the arterial waveform that we get, the machine can estimate the stroke volume and the stroke volume variation from changes in the wave contour of the arterial wave from the arterial line, and then they can estimate the cardiac output from the stroke volume and the heart rate. Okay, So this is a diagram of how this works. So the thermodilution works by measuring the temperature as a variation of the time after the injection of the cold bolus, and then they measure the temperature in the arterial after the injection through the central line. So this gives you a number, and it can help you calculate a lot of things through the machine. And then there's this pulse contour analysis looking at the waves of the arterial waveform, and this helps determine stroke volume and cardiac output and things like that. So what it gives you is it gives you an end-diastolic index, it gives you a stroke volume variation, it gives you a cardiac index, and a lung water, and a systemic vascular resistance. So this is very validated in the cardiac literature to help with fluid management, because if you have a high stroke volume variation, then you are responsive to fluids. If you have a high lung water, that means you're probably developing some pulmonary edema, and maybe we shouldn't give more fluids. Maybe the treatment paradigm is to now diurese. So this helps with the management of the fluid so that we don't overload the patient, and we can maintain cerebral perfusion during this phase of the treatment. Okay, so this is something that we use fairly frequently if we have sick patients. The other thing that we do is called a blood volume analysis. So this is a proprietary machine. It's made by a company called Daxor. And so this uses radioactive iodine bound to albumin as a tracer. Okay, so the tracer is injected, and samples are taken at various time points from the peripheral blood, and they measure the degradation of that iodine tracer in the sample. And so by doing that, it gives you an estimate of the blood volume of the patient. And so here's a printout of that data that we get. So we can tell what the ideal blood volume is, and we can tell what the actual blood volume is. So in this, imaginary patient, there is severe fluid excess, and so this indicates volume overload. So if there's volume overload, then we are more comfortable with diuresis if the patient has pulmonary edema and we need to reduce the volume of the patient. If they are deficit, then we think that they need more fluids and we don't want to reduce their blood volume. So this is something that has changed our management more than once when we get this information, because now we can have some data that says, are you dry or are you wet? And this helps, I think, in the management when we think that we need to increase the blood pressure, because are we going to give you fluids or are we going to increase the pressures? And so I think that helps with the management there. So those two things, the PICO and the blood volume analysis, are things we do in the ICU to help with the management during the vasospasm period. So now let's talk about controversies and difficulties of what we need to do. So I showed you cases where we coiled aneurysms. I showed you cases where we clipped aneurysms. Now, some places will stent assist coil during the ruptured phase. If you do that, you have to put the patient on dual antiplatelets. That makes me nervous, because if they need a shunt, then they're on dual antiplatelets for the shunt, and they can increase risk for hemorrhage while you're doing that surgery. So that's why we don't favor doing that. But so if we think that the aneurysm is not amenable to treatment without stenting, then maybe clipping is better. We sometimes think about bypass during the acute setting, but in the acute setting, there's also increase in thrombogenicity and increased hypercoagulability of the patient. So your bypass almost always goes down because it clots off. So doing the bypass during the acute phase is usually not well tolerated. So this stent-assisted coiling or even acute placement of flow diverters is very controversial. Decompression for high-grade rupture. This is not really borne out in the literature, but it's a practice that we do just because we think it helps. At some point, we're going to write up our series and see if it actually improves outcomes compared to our historical controls where we did not do decompressions for acute ruptures. Fluid status, we talked about that, Swan-Ganz, Pico, blood volume, all these things are tools that we can use to help assess fluid status during the vasospasm period. Hyponatremia is something that we struggle with. So if the patient is hyponatremic, are we still giving you 3%, 7%, 23.4%? The answer is probably yes, but what's the lower end that we can tolerate prior to starting to give you all these extra fluids, extra solutes, and things like that? We encounter this more often in younger patients and older patients because in young patients, their kidneys are very functional. And so giving them all this fluid usually doesn't change their serum sodium that much. And so now we're just giving them more and more and more fluids. And so you end up with, 10 liters in, 10 liters out of fluid in a day. And that, sometimes is not the best. We talked about the controversies between vasospasm treatment, balloon angioplasty, intra-arterial spasmolysis with calcium channel blockers, stent-assisted spasmolysis. There was just a recent FDA approval of a stent device for treatment of spasm. What we do is you navigate a catheter, you deploy the stent opens, and it has a innate radial force, and that may help with relaxing the smooth muscle blood vessel and maybe help open it. It's not something that we've done before, but it's something that is now approved. So that's on the in the future. And then shunt weaning. We talked about my protocol of not weaning, just clamp the shunt and then get a CT scan and maybe take it out or decide on a shunt and do an early shunt. New devices are coming in the future. Okay, we have these intrasaccular devices. So the Webb device, the Contour device, the Nautilus device, all of these are new devices, endovascular devices that inside the aneurysm without needing stenting to support coils for wide neck aneurysms. Surface modified flow diverters. So flow diverters are high density stents that we place to reduce flow into aneurysms. There's research into modification of the metal so that it's less thrombogenic. So is there some potential future in which we were able to place stents into these aneurysms or into the vessels to stop flow that we don't need to put them on dual antiplatelets? Maybe we can just put them on single antiplatelets. Then that may be more tolerated than duals. And then critical care management. We talked about fluid status. We talked about volume management. Some people place patients on continuous EEG to see if that will change your management, but we haven't done that. This is a cartoon of intrasaccular device. This is called a Webb device. Essentially, it's a either cylindrical or spherical and it slows flow into the aneurysm so that there's stasis in it, and that causes occlusion without needing a bridging neck device. And so you can place this device and not have the patient on antiplatelets because there's not metal in the parent vessel. So this is FDA approved. This is used by a lot of people. Here's an example. This is a wide neck basilar aneurysm. There's a device you can see in here, and then here's the follow-up where there's really no more residual because now the neck has been remodeled from the base of the device. So this is the intended indication for this device, a wide neck bifurcation aneurysm. Okay. Along a similar line, this is the Contour device. This is a device that's not yet FDA approved. This is CE mark approved. And so it is undergoing its initial approval in the US with the FDA right now. So this is a instead of being a ball or a cylinder, this is a cup. And so you place the cup at the neck of the aneurysm, and the idea is that this slows down flow into the aneurysm to induce stasis and thrombosis. And then again, you have occlusion at the neck without need for antiplatelet devices or antiplatelet medications. So again, here's an example. Wide neck aneurysm, a device is placed at the neck, and that slows flow down. So if you don't have this device, this aneurysm is either stent coiled or clipped because there's no way that you can place coils in this without occluding the parent vessel. So that's the use of the contour device. But as with all these intrasaccular devices, they sometimes don't work according to plan. And so these are a few pictures that I found, online of failures of these intrasaccular devices. So on the left, we have a contour device that was placed. It migrated into the dome of the aneurysm. A residual was left, and it was treated with a small web. On the right, this is actually a post from LinkedIn where they are showing the efficacy of these flow diverter stents, but they also showed what they did to another aneurysm here. So I focused on this as opposed to focusing on what they were trying to focus on. And I saw this. This is a web device that was placed, likely undersized, and so it migrated into the dome of the aneurysm, and they treated the residual with a contour device. So, these new technologies have to be used in the right patient, because if you don't size them appropriately, if they're not placed well, then they will migrate, and then you have residual or recurrent aneurysms. Okay. This is a new device. This is called a Nautilus device. This essentially is a helical neck bridging device that's placed at the neck. It's also an intrasaccular flow diverter device. But the idea is that you deploy this and it will accommodate the shape of the neck, and you can either support it with coils or not. The initial paper supported it with coils, and so this is another just a device that is used. And here's an example of that device. So here's the initial placement of that helical tornado device at the neck, and then they fill it with coils, and you can see that the aneurysm is well thrombosed on follow-up. So another device that may work quite well. We'll see how this works. This is also going initial trials in the U.S. Here's that flow diverter that we talked about. This is a cartoon here. This is a high mesh density stent. The idea is that you're redirecting flow through the parent vessel, and you're causing stasis and thrombus in the aneurysm at the sidewall. The branches of the vessels that are arising from the native vessel are maintained open, because this is not a covered stent. This is an open cell stent. So if there's a vessel, it'll be okay, because it will not be occlusion of the vessel. But if there's a blind pouch like an aneurysm, this will cause thrombosis. And so this is the ideal scenario where you deploy the device, the device is deployed, and you have thrombosis of the aneurysm here. Okay. These are high mesh density stents, so they require dual antiplatelets. So sometimes, if you are forced to, you may have to place a flow diverter during a ruptured phase, but it's very risky because of the need for dual antiplatelets. Okay. So this is what we talked about: the high wire density stent, dual antiplatelets, either aspirin and Plavix, or if you're a Plavix non-responder, we'll do ticagrelor, which is another antiplatelet agent. And so this is our regimen usually for patients who are getting this in an elective fashion. If you're giving it for an emergent fashion, you may have to give Riopro or tirofiban or some kind of IV antiplatelets to inactivate them prior to deploying the stent. But we use it mainly for unruptured aneurysms around the carotid siphon, so ophthalmic artery aneurysms, cerebrohypophyseal artery aneurysms, sometimes posterior communicating artery aneurysms, and anterior carotid artery aneurysms. Okay, but not really for bifurcation aneurysms, so not for middle cerebrals, anterior communicating, things like that. Now, the next generation are surface modified flow diverters. So each company has their own proprietary mechanism to try to reduce the thrombogenicity of their device. So Medtronic has a device. They have phosphorylcholine on the inside of the stent, and ideally that reduces the thrombogenicity of it. Phenox, another company that has another stent, they have this HPC, which is a proprietary hydrophilic polymer coating. The HPC, they say, mimics the glycocalyx of the endothelium to confuse the platelets so that they don't stick to the stent. They think it's normal vessel. And then this Derivo device, they have this metal blue oxide surface finishing that they say reduces the thrombogenicity of the device. So maybe there's some opportunity here for devices with less thrombogenicity, and maybe they would be applicable for treatment of the ruptured aneurysms, but things are yet to be seen. So maybe you can even do single agents over dual agents due to the decreased thrombogenicity. That's yet to be determined also. But people have looked at small series where they place flow diverters for ruptured intracranial aneurysms. Okay, a standard flow diverter, many papers and meta-analyses, mortality between 16 and 18%, re-rupture rates pretty high, 10 to 12%, and good outcome, it's a very wide range, 45 to 80%. They do say that patients who survive, there is a good occlusion rate, so that's good. But this is not promising. Almost a 20% mortality rate is not good, and this is a very, very high re-rupture rate. Okay, if you take the small studies that use surface modified flow diverters, their mortality was still about 15%, which may just be that mortality for ruptured aneurysms is high. It may not be from the device that's used to treat it. But there were still lots of paraprocedural complications, 20% thromboembolic complications, 10% hemorrhagic complications, and occlusion isn't as good, which may be because of the decreased thrombogenicity of the stent. So maybe it is that we do need some thrombosis outside the stent, and we're not getting it because of all the surface modifications of the device. So I think the takeaway is it's still very risky to place these flow diverters for ruptured aneurysms. But if you have a dissecting aneurysm, or if you have some anatomical consideration that you can't clip or you can't coil, this may be the only thing that you can do. So it's something that we keep in mind. Now the critical care. So in my mind, the next step is clazosentan. This is an endothelin receptor antagonist. There were multiple trials, Context 1, 2, and 3 trials that showed no overall benefit with endothelin receptor antagonists in aneurysmal hemorrhage. They showed that there was a decrease in the risk for vasospasm, but there was overall increased risk for morbidity because of medication. So they stopped trials and they said it's not helpful. Most recently, there's a REACT trial, which we were part of. This is a multinational randomized double-blind controlled trial where they gave endothelin receptor antagonists to patients with higher risk for spasm. And so these are modified Fisher 3, modified Fisher 4 patients who have high risk for vasospasm. The thought being, well, if you gave this drug to all comers, then the patients with low-grade hemorrhage could potentially have a morbidity from the adverse events of the drug and not as much benefit from the medication itself. So if you exclude patients who are low risk, maybe that's a way to focus the benefit of the drug. And so there's a Japanese paper that showed promise in reducing vasospasm in hemorrhage patients with clazosentan. So the results are still being tabulated. It'll be another 6 months to a year before we figure it out, but we're hopeful that we can show that there's a benefit in these high-risk patients with clazosentan. And that is all I have for you. And if you have questions, I'm happy to answer them. Otherwise, I'm sorry for going so fast and over so much stuff.